Sweden's first randomized, double-blind trial of psilocybin for depression just reported results that are hard to ignore. Researchers at the Karolinska Institutet gave 35 adults with moderate to severe recurrent depression either a single 25 mg dose of psilocybin, the active compound in so-called magic mushrooms, or an active placebo, alongside structured psychological support. By day 2, the psilocybin group already reported fewer depressive symptoms than the placebo group. By 6 weeks, 53% of the psilocybin group were in remission, compared with 6% on placebo, and the improvement held for more than 3 months. The study was published in JAMA Network Open in May this year. Headlines have already started calling this a cure. It is not that simple. And it is not that complicated either. Let us sort the signal from the noise. Standard antidepressants, the SSRIs most people are prescribed, work by slowly adjusting serotonin levels in the brain over weeks. And roughly a third of patients do not respond to them at all. Psilocybin works differently. Once metabolized, it strongly activates a specific serotonin receptor called 5-HT2A, which appears to temporarily loosen the brain's default mode network, the circuit associated with rumination, self-criticism, and the repetitive negative thought loops common in depression. Brain imaging studies describe this as the network becoming less rigidly locked into its usual patterns for a period after dosing. Researchers believe that temporary disruption, combined with structured psychotherapy delivered before, during, and after the session, is what allows some patients to exit long-standing negative thought patterns rather than just numbing them. That is the theory behind why one dose, taken once, might outperform a pill taken daily for months. It is plausible biology, not proven certainty. The details of how this trial was built matter more than the headline number. Psychedelic trials have a well-known blinding problem. Participants can often tell within minutes whether they got the real drug or a sugar pill, which can inflate results through expectation alone. The Karolinska team tried to close that gap by using niacin, a vitamin that causes a noticeable flushing sensation, as an active placebo. So both groups had some physical reaction to react to. Every participant also received psychotherapeutic support on 5 separate occasions. Before the dose, during the psilocybin session itself, and in follow-up sessions afterward. That means what got tested was not a pill in isolation. It was a full clinical protocol. Drug plus trained therapist plus structured preparation and integration. Strip any one of those pieces out and this result may not replicate the same way. That distinction gets lost almost every time this study gets summarized in a headline. This trial did not happen in isolation. It lands inside a decade-long push to bring psychedelics into mainstream psychiatry. The FDA has granted breakthrough therapy status to psilocybin for depression. Larger trials from companies like Compass Pathways and non-profit research groups like Usona Institute have reported similar rapid, durable effects, and Oregon and Colorado now allow supervised psilocybin use for adults outside the clinical trial setting. Still, psilocybin remains a Schedule I controlled substance under United States federal law. And most countries still classify it the same way, meaning access anywhere outside an approved trial or a specific legal state program remains illegal. The gap between promising clinical results and legal, insurance-covered treatment is where most psychedelic medicine research currently sits. Years of trial data stacking up faster than regulation and infrastructure can absorb it. Insurers have not yet worked out how to reimburse a treatment built around hours of supervised therapy rather than a daily prescription, which is its own unsolved problem long before any of this reaches a typical doctor's office. 35 people is a small trial, run at a single site, in a single country, and results that strong in small samples do not always hold at scale. The active placebo helped with blinding, but did not eliminate it entirely. Patients flushed from niacin can still often tell they did not get psilocybin once the session unfolds. 3 months of follow-up shows the effect is not purely a same-day illusion. But it is nowhere near long-term safety or durability data. This treatment also is not a pill you take alone. It requires trained clinical staff present for hours-long sessions, making it expensive and difficult to scale even if approved tomorrow. Psilocybin also carries real risk for people with a personal or family history of psychosis or bipolar disorder, and unsupervised use outside the clinical setting has led to documented harm. None of that erases the result. It does mean this is early-stage evidence, not a finished treatment. Quick recap. Karolinska Institutet researchers ran Sweden's first double-blind trial of psilocybin for depression. 35 patients, 125 mg dose plus structured therapy, and found 53% remission at 6 weeks versus 6% on placebo, holding past 3 months. So, signal or noise? Signal. This is a real, peer-reviewed, properly blinded randomized trial, adding to a growing pile of similar results from other labs. And that consistency across studies is meaningful. Noise risk shows up the moment this gets flattened into mushrooms cure depression, skipping past the trained therapists, the 5 support sessions, the small sample, and the fact that this remains illegal and unapproved almost everywhere outside the trial. The honest takeaway: a genuinely promising treatment still years from your pharmacy, not a weekend self-experiment. Subscribe for medical research explained before the hype gets to it. Signal from the noise. Every week.